Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by Socially Determined. Our presenters today are Trenner Williams, CEO and founder of Socially Determined, and George Aloff, President and CEO of CareFirst. They will be presenting the webinar, How Health Plans Benefit from Going All In on Addressing Social Determinants of Health. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now I'll pass it over to Trenner and George.
Ron, thanks so much. And thanks to ACAP for allowing us to have this conversation today. I think when George and I talked, we talked about a fireside chat. Neither one of us are sitting by a fire and nice chairs, but really appreciate the opportunity to speak with ACAP members about social determinants of health, a topic that is, I know, near and dear to everybody's heart. And I am especially privileged to be here with George Aloff, the president of CHPDC, as part of CareFirst, and talk about that. Just real quickly, by way of background, I'm going to give this over to George to talk about his background in just a second. I'm a family doc by background and training. I've had the privilege of being the CEO and one of the founders of Socially Determined. We're a SDOH risk analytics platform, and we have the opportunity to partner with health systems and health plans, including lots of Medicaid plans across the country, and really excited to be here with George. George, why don't we just start with that, with an intro, your background, your story, and then we'll dive into the work.
Thanks, Trenner. As mentioned, I'm George Aloff, President and CEO of CareFirst Community Health Plan, District of Columbia. Just a little background on the company. We were a startup organization back in 2013, small company called Trusted Health Plan that was serving Medicaid beneficiaries here in the district. We operated for about 8 years up until last year when we were acquired by CareFirst, Blue Cross Blue Shield. What's pretty amazing about our journey through the years is that we were a small minority-run organization, and our original slogan was the only plan east of the river. We put our offices and our infrastructure in the parts of DC where Medicaid members lived and worked and played. And that was something that we really took a lot of pride in. As the years have gone by, our mission really hasn't changed. And if anything, it's gotten even stronger through the acquisition by CareFirst, Blue Cross Blue Shield. So a lot of the stuff that we'll talk about today, we'll talk about how partnerships with companies like Socially Determined is really enhancing the work that we're doing, and ultimately our mission to make the underserved populations have access to the same healthcare that everybody else does.
George, I'm not going to let you get off that easy. I appreciate about the company. What about you? Tell us a little bit about you and your background.
Yeah, so I mean, I've been in healthcare what seems like forever, but I've been in the Medicare space. I've been in the Medicaid space. Worked for CMS, and then for large organizations. As mentioned, did the startup thing with Trusted Health Plan, and now back at a larger organization like CareFirst. What's really exciting about where I'm at today is that I really like make a huge impact on the community, being a part of a large organization where we have Medicare members, we have Medicaid members, we have commercial members, we have exchange members, and really what we're trying to do is be there for our members at every stage and circumstance of life. As you know, folks can go into all sorts of programs during their lifetime, and our plan is to be there at every aspect of it.
That's great. I appreciate it. And as we go through, just for the attendees, George and I have some slides that we'll talk through, but we also expect to take some tours through some different questions and answers. And as Ron said, as we get to the end, certainly would love to hear your questions and thoughts. George, you gave a little bit of the background just now on the organization. What I'd love to hear, especially with the integration with CareFirst and the resources that potentially brings to you all. Talk a little bit just about the mission, or maybe expand on what some of the sentences you just said before about what you all can do, what you want to do, and how that's going.
Yeah, that's a great question, Trenner, because what we want to do has not changed, right? Ultimately is to serve these members. I think that, I sat in the seat prior to the acquisition in a community health plan that was smaller, that really did a lot of great things, right? We were in the community, we hired from the community. We put health and wellness centers throughout the neighborhoods where our members lived. We offered programs and different sort of interventions that we felt would really solve a lot of the issues that we're having. We really believed that, we were playing in the space of SDOH before it became a popular thing. And then now, migrating over to CareFirst, you realize you need so much more to be able to scale what you're doing as a whole, right? So the hands-on approach is great, but for a lot of the community health plans, as they start to grow, it's harder and harder to sort of do the work that you really want to. And so in order to be able to continue to serve that mission, you need technology, you need infrastructure, and you also need analytics, like some of the stuff we're going to talk about today, to really be able to do the hands-on approach that you used to be able to do when you were smaller. So really exciting to have companies like Social coming up with solutions to sort of bridge the gap. When you think about the larger companies, oftentimes they're too far removed from the neighborhoods and the communities that they technically serve. You think about the smaller companies, they're there, but they don't really have the bandwidth to really serve at a larger scale. There's got to be something that marries the two sides together.
I love it. And it just makes me think, George, sometimes when you're really large, but you don't have that local touch, organizations can have the tendency to try to helicopter in and do things to the community and not with the community. With how CHBDC started with Trusted, right? As a local community plan, and now with the infrastructure, I would imagine that gives you that perspective and that ability to do interventions and support with the community and not to the community. Is that fair?
It's a very fair statement. And I think what we're really trying to steer clear of is doing interventions to the community, right? Because we are the community, right? We hire the community, these similar communities in which we serve. And so I think it's really important for the members to understand that we set up that infrastructure on purpose. And what's been really great is that the parent company that we're now a part of fully appreciates and values that. And I think that's one of the great things about being new in this space, is that CareFirst, all of us together, we're really learning how to navigate this new space together and what makes the most sense. So being within the community is something that has not changed post or pre-acquisition, which is great.
That's great. So we're going to walk through now sort of after admission. And again, a lot of these questions will obviously build on each other, and I don't want to overlap too much, but when you think about not just from sort of the human component and doing the right thing, but the integration of what is right with your strategic business objectives. Can you talk a little bit about the decisions and how you all think about social determinants of health and the investments that you need to make into programs, into resources, and into partnerships, and how that alignment with mission and altruistic point of view with business, how that works for you all?
Yeah, I mean, it's a great question, right? So, I mean, ultimately, when you're serving this population, engagement is so key. And it's so much more complex than I think a lot of people appreciate, especially with the populations that we serve. It's not often is it the case that they just don't want to engage. There's often barriers to engagement, right? Whether it's folks are working multiple jobs, or whether folks are sick, or they're taking care of loved ones, or maybe they have, there's just too much on their plate for them to engage with the health insurance company. How many of us are that engaged with our healthcare companies, right? So I think that understanding our members and understanding what they're going through, their daily lives, what's keeping them from really paying attention to their health is critical, right? I mean, I know it goes without saying, but you're not going to be worried about your diabetes if you're worried about where your next meal is going to come from.
Right.
You're not going to be worried about, getting your kids to this appointment when ultimately you're just trying to get your kids to school and get them to school on time. And so I think that one of the things that we're really focused on is making sure that we prioritize those things that are going on in our members' lives. How do we help them with that so that we can come in and also help them with their healthcare after that?
I love that. We're going to talk a lot about that visibility. I'm smiling. I talk a fair amount about we can be egocentric in healthcare. And I say that as a physician and as a former practicing family doc. We think that our patients, your members, they must be only thinking about their diabetes. We see them in our clinic maybe 3 or 4 times a year, maybe for 15 or 30 minutes. And they must be thinking about their diabetes when they're not in our clinic, right? I'm sure that's what's going on and that's top priority. And it's not. We know it's not, right? They're the choices that people are faced with every single day, right? Whether am able to keep my lights on to put healthy food on the table, do I have available transportation to get my kids to school, my family, maybe multi-generations there. And this opportunity to look outside, right, of the traditional healthcare data that we've used to make a lot of decisions, there's this massive opportunity, right, to open up the aperture, to have visibility and understanding of what's going on in people's lives. And if we understand and we have that information, I think we all believe we can actually do something about it.
For sure.
All right. So, we talk about at Socially Determined this idea of social risk intelligence. Again, it goes to the idea of visibility, of understanding whether it's food insecurity or housing instability, financial strain, health literacy, transportation risk, these factors of life, right, that influence and inform so many of the decisions that we make. And historically, we haven't had in healthcare a lot of that visibility and a lot of that understanding. So as you start to learn more about at a very member level, how do you think about using that visibility, that information, that intelligence to better understand what's going on in your members' lives?
Yeah, another great question. So for us, one of the things that we really preach within our organization today is that it is not one size fits all approach with the Medicaid populations. And I think that so much of the healthcare community wants to make it that way, right? One side, and I think that we're even guilty of that ourselves as a community plan. These are the programs that we need. These are the issues that our members are going through. The reality of it is the Medicaid population is just like any other, population in the country. Everyone's unique. You have, working class professionals, you have folks that unfortunately will have mental health issues. You have veterans, you have, homeless members, you have families, you have single mothers, you have everything across the gamut, and their needs are totally different and unique. So I think that when you think about how do we manage and support this population, you need more information as to what sort of categories and buckets these folks are fitting in, and then how do we address them? And you're not going to be able to address everybody one-on-one. That's impossible. But if you can put them into, oh yeah, this person is having housing issues, right? There's a whole class of people that are having housing issues. How do we address them and find them? Maybe we have a text campaign to those members that we have identified through SocialScape that have housing issues and connect them to the community resources that are right there to help them. I think one of the things that we realized a long time ago was that there is a lot of community resources out there in a lot of markets, but especially where we are, that folks just don't know about and just don't use. And a big part of our responsibility as a health plan is let's connect them to that. So we have a number of case managers and outreach workers and social workers that their job is to take this information that we now have better access to because of SocialScape and say, hey, here you fall into this category of people that have these issues. Did you know there's folks out there that can help you with that? So that's our goal, right, is to connect them to those resources.
I love that. I want to hit on one of the things you said too, because I think and my sense is probably not our attendees today in the community health plans that are serving a Medicaid population. But I would say in the industry, what we have seen is that different people in healthcare believe that all Medicaid is the same, right? That they're poor, therefore they are on Medicaid. And so everybody is high risk from a social determinant of health standpoint. And I think what we found every single time is that diversity, right, in the populations at an individual level, that people don't look exactly the same. And when we start to make those assumptions, we miss huge opportunities to actually help in the right way as part of that. The other thing I think that we found tied to that is that many times people don't have a single area of risk, right? It's not just food, or it's not just housing. And part of, I think, what we've seen is the opportunity to understand all of those risks, maybe at a domain level. So, but being able to look and say, what percent of people have multiple problems? What percent of people have both food and transportation risk? So as we think about interventions that might work for somebody, if it's food availability or the lack of availability of healthy food, if I also know that they have a transportation problem too, I might think differently about how I solve for that than only sort of thinking about one domain at a time. Does that resonate with you?
Yeah, completely, right. And another way to look at it, so all of us in the industry, we have health risk scores, right? And a lot of times in Medicaid and Medicare, you get paid based on these health risk scores. And so those members you're seeing, what's going on with them because they're in the hospital all the time. They're seeing providers all the time. And so you're getting a good gauge of what's going on with those members. Within the Medicaid population, there's so many that are just, for the most part, appear healthy, unengaged members. They're not going to hospitals. They're not going to doctors. And so you're getting paid your cap rate for these members, and for the most part, they're quiet. What you have to worry about is the catastrophic event that could and may happen, right? That oftentimes does happen. The 20-year-old or the 30-year-old that didn't realize that they had high blood pressure, or didn't realize they had, diabetes and other issues. And so one thing that is really critical to us is that we all have the health risk scores, but it doesn't tell the full story. Sometimes the health risk score looks really low, and this person's super healthy and we don't have to worry about them. But what about the social risk score? What are the other factors that are going on in their life that could be an issue down the line that just hasn't showed up yet? And so that's why I think this work is so important.
Well, I know the answer, but our audience members might not. So when you're thinking about social risk, you're not just looking at those individuals who've had a claim in the last year or that have a chronic disease. You're looking at your entire population. Is that right?
Absolutely. Absolutely. And the reason for that, Trenner, is because the folks that have a claim, you have some, history, you have some facts on them, you have some background. It's the folks that aren't seeing anybody that you really have no clue what's going on with them. And if you're not able to engage with them and understand what their risks are socially, using that to engage with them and then getting them into, just go have a well visit. Because at that well visit, you might discover something, right? Something that's been hidden that they have no clue about. And if you don't address it in your 20s, it could become a problem in your 30s, or 30s, it becomes a problem in your 40s. So, we've been there. We're getting older, so we understand that.
Wait, speak for yourself. I'm definitely not getting older. So one of the other things that makes me think about is, as you all get new members, right, on a regular basis, and you don't have historical claims on that new member population, one of the first things that you can have, so as new members come in, is their social risk profile and the specific risk areas that allow you to prioritize and proactively reach out to people ahead of time. So it's not just the unengaged people that maybe you've had for a while. It's taking an opportunity to get information right away when you have new members join, and how that might help you avert potential catastrophic cost, or again, utilization, or again, challenges that those members are going to have.
Yeah, absolutely. I mean, another thing to think about when you look at it from a case management perspective, or even just an outreach perspective, we have a ton of programs and interventions that are out there. But one, how do we make sure that they work for the issues that folks have? But then also, how are we actually getting people to utilize and attend these programs? Yeah. So part of that is being able to marry up, who's actually has the issue that this program is trying to solve. Let's find them, let's connect them. So having those social risk scores gives us a heads up when we're first engaging with the member to say, hey, by the way, we have this program and that program, come to our wellness center, we can help you with this. Yeah. Understanding, the risk scores will really help us understand what those are.
That's great. All right. So again, some of this is maybe early days, and as you are thinking about this, but do you have a sense yet, and whether, again, not thinking about even working with us or anything like that, but just your focus to date on social determinants of health? And maybe you can also forward look, have you seen any improvements in business performance? And B, importantly, what are you thinking of measuring? And what's going to become important from a business performance standpoint? What are those metrics? And certainly, hopefully, not all of them are financial as you think about performance as part of that.
Yeah, there's so many, right? So let's start from the beginning, right? So one of the bigger issues in healthcare, and I'm interested to hear your opinion on this as a doctor, is no-show rates. So the no-show rates within the Medicaid population are insanely high, right? So you'll see them up to 50% in a lot of markets, and that becomes a frustrating point for the providers themselves. So for us to be able to understand who's not showing up, why they're not showing up, and how do we address it and fix that, it's not as simple as just to say, hey, we offer free transportation. That might not be the issue. There might be other things that we need to address. That's at the very core of the provider-patient relationship. But if you look at from an insurance plan perspective, HEDIS measures, oftentimes folks have pay for performance programs. All of these are basically trying to get optimal utilization, right? So having members do well visits and go to the PCP and take care of their health proactively versus just ending up in the ER, which ultimately ends up in an inpatient setting. And so when you think about addressing a lot of those types of metrics that most of us Medicaid plans have to perform on, a big part of it is just understanding the why, the root cause. Why are folks not showing up? Why are folks not doing this? And how do we get them to show up? I think those are two big areas that we started. We're still young in our relationship, Trenner, but I think that another thing we're also thinking about is, as we start to do marketing and outreach to our members, how do we offer what the members really need and want in order to not only grow our membership, but also retain our members? Ultimately, we want them, if they're here, to really appreciate what we're offering and stay with the plan. So I look at it from all those different perspectives. The social risk scores and SocialScape can really help us really understand root causes for all those things and help us advance our business performance in a lot of aspects.
Yeah, you triggered a couple of things for me. Maybe we can dive into. I remember we had the opportunity to support a health system in the Midwest, large Medicaid population. We were specifically focused on maternal health, so prenatal, first year of life after, and identified really high no-show rates, just like you said. And I remember sitting down with the CEO of the health system, who was also a physician, and he was like, "We have a transportation program." I'm like, "Yes, sir, you do." It turns out it was a van that goes around the entire city. So it does one loop and it can pick people up along the way. It ends up being over a 3-hour trip to do the full loop as part of that. So you may be missing an entire day for a 15-minute visit. You also could not take children under 5 on the van. And many of the moms that we found, most of them already had 1 or 2 children as part of that. So if they're under 5, you just eliminate, you think you're doing the right thing and addressing a need, but you haven't actually, you said some of this before, but engaged with the community to find out what matters to them and what their real needs are. And so let me ask you this question, as you think about business metrics in the future, one of the, I think the value opportunities that we've seen for organization is not just metrics that matter to a plan, but that matter to the person. So I've seen a financial opportunity center with a Medicaid population in Ohio, and one of the metrics, or 2 of the metrics, were really person specific. One was tied to the average increase in monthly income for those participants 6 months after the program. And the other was the increase in their credit score that allowed them, right, to get better loan rates and other things like that. Because it turns out that those individuals who were enrolled cared less about avoidable inpatient admissions and ED utilization. Yeah, they didn't want to go there if they didn't need to, for sure. But what mattered to them is that on average, they were making more than $600 more a month after that program, or that their credit score was over 100 points higher. Any thoughts on sort of those personal metrics?
Oh, I mean, and that's a big part of what we're trying to address, because we realize that is the number one barrier to members getting healthcare, or a lot of them around that. So we've developed, financial literacy programs, credit repair programs. A big thing that we're doing in our market that in a lot of urban markets is we have English as a second language, right? So it's another huge part that is causing barriers for our members. They don't speak the language. It's hard to get gainful employment. And it's also hard to navigate the healthcare system sometimes when you don't speak English as a first language.
Sure.
So that's a big part of what we're trying to quantify for our members is, education. We're helping with GEDs. We're helping folks get jobs. We have, all of our wellness centers have labs with computers and printers. We're helping folks with resumes, right? So that's the real metric for us is, job rates, income, education levels, right? Getting people set up to be successful in life so then they can be successful in health.
So I'm going to ask this question, and it may seem silly considering you and I are having this conversation, and this is the work that you all do, and I would imagine the vast majority of the plans that are on the line today. What you just described is amazing, right? And that focus in people's lives and the support that you're providing. It's an interesting question to ask. Is that a healthcare plan's responsibility? Right? In our U.S. healthcare system, I think it's amazing that we can do those things because maybe nobody else is. Any thoughts? I don't want to hit a third rail for us or for anybody else, but thoughts on healthcare's responsibility to take on these things that many might think are outside of a healthcare purview?
That's a great question, and it's a popular topic nowadays. I do think that it's everybody's responsibility to help, and I think that if you're in a position to help, it's definitely your accountability to do so. And if you think about with these members, there's not always people in positions to help them. The healthcare plan is in position to do it. As you probably know, now a hot topic in the industry is do Medicaid and government programs start to fund some of these programs around social determinants of health, right? Because they realize that we have access to these members. We have a way of improving these members' lives, even though we're the healthcare company. Maybe we build this as a part of our program. So for us, we've been doing it for a decade. I think everybody on the call right now is doing it to some extent now. Social determinants is healthcare. This is why they call this the social determinants of health.
I of course believe. I just wanted to thank you for saying all of that and so eloquently as well. All right. So, whoops. So, and this will get into some of that as well, because I think the opportunity of not doing things to the community, but instead with, a lot of that starts with our local partners. So how do you all think about expanding the relationship that you all have, that identification, that understanding of supply and demand? If demand is risk and supply are the amazing organizations across the city and the region, maybe nationally even, that can help address that risk. How do you think about those community partners and what you all can do, and how do you support them in this journey as well?
Yeah, it's so we can't do our jobs without each other, right? And so we really can't manage these members without all the wonderful community-based organizations that are out there, and vice versa. And so what we really need to work on is better connections. Really making sure that we're connecting members to the right organizations, because we're automatically connected as their health insurer. And we have access to them in a way that a lot of other folks don't. And so being able to help them, and if you think about, us and looking at SDOH and working with your platform, being able to understand what their needs are and then being able to connect them to the right community organizations is so important for all of us, right? It's important for us as a health plan. It's important for the member, of course, but it's also important for the CBO because they need access to the people that need the help. We spend a lot of time talking to these folks. Also, if you think about the FQHCs, in a way, these folks have a really direct line. You think about the FQHCs, members will listen, the patients will listen to those docs at their community health centers, and making sure that we give those folks access to all the information that they need, because oftentimes they're the best communicator to the member. They don't want to hear me, they don't want to hear you, Trenner, for sure, but they want to hear what their provider has to say directly, because that's who they trust. And so I think we have a big responsibility as a plan to arm the community-based organization, arm the provider, arm the FQHC with the information that we're able to gather through technology and analytics, and say, hey, now you're up now.
Yeah, the word, if you didn't say it, I was going to bring it up, but it's trust. And when you think about that, I assume that's why your past plan was called Trusted as well. But that T word really matters. And you think about that opportunity, right? When you have built trust with a person, with a family, that you get the privilege of being able to provide support and help. Now, part of that, I would say, is the mission that you all have and the work that you're doing, tightly aligned with the FQHCs, with other providers and those community programs. Also, you're building trust every single day. And that really, really matters as part of that. So I love that. Any thoughts on the role of either like your foundation or other foundations as well? So in addition to the community partners, so you and I both, and probably lots of other people, we all either sit on nonprofit boards and CBO boards and other things like that. And many, right, are challenged with capacity building and bandwidth, want to do more work, but don't have a lot of infrastructure as part of that. Any thoughts on sort of the role of foundation or other foundations in support of community partners as well, and how you all can help to bring some of the either those resources or funds to the table as well?
Yeah, and that's been a big conversation recently, and it's come up because of COVID vaccinations, right? And so if you look at, across the nation, the vaccination rates for Medicaid members are way far behind the rest of the community. So here in DC, vaccination rates are in the mid 60s, and for the Medicaid population, it's closer to 40%. And so when you think about that, it's a combined effort that us and the foundations and community organizations have to think about together. How do we address these problems together? And the first, reaction, especially from a foundation perspective, is we have money. We'll give you money, right? And what do we need to solve? And you realize with situations like this, money is not going to solve the problem, right? Information and education is going to solve the problem. And so, how can we use, the information that we're getting through analytics and through all this information we're talking about today, to work with these organizations to actually make an impact, right? So sometimes it's not dollars and cents, but it's just information and education, and that's how we're going to help the members. So I think that's our real role in this ecosystem of healthcare and helping members.
Love it. So as you think about maybe advice, both what you've learned and what you all do, maybe what you've learned and you no longer do as part of that, what other health plans could consider as they build their own programs? Any advice that you would have, lessons learned, wisdom?
I love this question. The reason I love it is because it's a chance to be really honest. I think that as a community health plan, you do a lot of good. You have a lot of ideas of what is good. And what the members really need. But then if you ever take a step back and realize, is this really working? What is the ROI on these programs or these interventions? We have tons of outreach workers, which we're so proud of, and we're hiring them from the community, and we love that, and they can talk to me, but how many members are they actually talking to? How efficient are they, right? And same thing, we look at the programs. How many people are coming to these programs? And are these programs working? If someone's been involved in one of our interventions for 6 months, is there a real impact? Are we seeing that? And I think that for us, we had a lot of great, intellect early on as a community health plan, and bringing on experts from the communities to know sort of what we needed for our members. But as time went on, we weren't evolving enough, right? And so I think for health plans out there, I think folks really need to take an honest look at the programs, the interventions that they have, and are they really working? Is there a real ROI, and not just financial, but an ROI on health for those members? I think it was a brutal truth for me to face, to look at something that we've been doing for 3 years that we talk about every time I'm on one of these panels. Yeah, we do this, we that, but is it really working? Yeah. So I think it's important for plans to look at their programs, interventions, and really test it out. And I think another thing, to think about is scale. Community health plans often do such great work, but as they get bigger and bigger and bigger, the approach just doesn't work. And that was the biggest challenge that we had in the last year. So we doubled in size over the last 12 months. And the bigger we get, the harder it is to really have that hands-on approach. And so that's really what drove me to call you, right? Is I need to be able to scale the model that we have, and we need information and data to be able to do it. So I think for health plans out there throughout the country in different markets, think about your programs and if they're really working, and think about how you can do this really good work, but scale it as you get bigger and bigger.
Yeah, I'm going to build on that and talk a little bit, maybe just for a second, about the work that we're starting to do with you all. We talk about the what, the so what, and the now what, and a lot of the work that we do. So what for us is you identify what risk looks like at a person and in the community, incredibly valuable at the member level. The so what is actually integrate that information, that social risk profile and understanding with claims data, So you can actually say it's this group of people, right? It's the diabetics, right, who live in Ward 7, as an example, who have food insecurity and health literacy challenges, where there's a real opportunity. That quantification of what the opportunity in leads to prioritization, right? At the end of the day, you can't do everything for everybody. So prioritizing which interventions around which domains, in which areas, and DC is a relatively small geography, but still all the diversity we have in neighborhoods across the city. How do you think about that prioritization process? And so that's the now what part of launching interventions. The critical piece to all of it, though, is the measurement, right? And what we're doing together, right, is actually measuring the effectiveness, the return on investment, not just financial, but sure, utilization and cost as part of that, but impact on clinical outcomes, which means partnering with FQHCs to better understand, right, the clinical biometrics and clinical outcomes as part of that, and person level metrics, member level metrics that matter to them, right, that actually improve their lives as part of that. So I think both the desire to, but also the discipline to measure, when I think about where other health plans are, like that discipline, that commitment really, really matters.
Yeah, and you made me think of something, Trenner, is, so for us, we met, you're headquartered here in the district, and so are we. And so you've already had work, and so it was a logical, fit. But, if we're, folks on the call here, if you're in St. Louis or if you're in Miami or in another market, how does Socially Determined go about building this infrastructure in those markets to help those plans?
Well, thank you for asking. The part of when we started as a company, even though we're based in DC, what we believed it was important to look across the entire country. So we only work domestically, but all 50 states. We've been able to quantify social risk for every community in the country. So we actually quantify SCORE, food insecurity and housing instability, financial strain, at a 200-meter view, which is tiny. Like if I had a better arm, I could almost throw that far. But for every 200-meter plot across the country, we quantify what risk looks like, so that we know whether it's St. Louis or Jefferson Parish in Louisiana or out in Southern California, what risk looks like on the ground. And we work with national foundations, national plans, national employers, so that no matter where their members or patients or employees might live, we can provide a view of what that risk looks like. The other part of that is we've helped to build, I think, a really thoughtful set of partnerships with data providers. So when we work, and we need to know what the community resources look like on the ground. So I know where every fast food restaurant and full service grocery store and food bank is in the country. Because when you're thinking about food insecurity, there's no magic piece of information from the USDA that lets you know about the availability of healthy or unhealthy foods. But if I really want to look at that and address food insecurity, I need to understand if somebody's driving past 9 fast food restaurants, right? Or in a bus on the way back home from work, and that's all they pass, and there isn't a full service grocery store in their neighborhood. And so using national data sets, I think for us has been really helpful, so that we can partner and be thoughtful partners anywhere in the country. So thank you for asking that.
Yeah, awesome.
Before we, and I think we have a few more minutes before we open it up for questions, and we might do that a couple of minutes early. When you think about addressing social risk, do you as an organization and you as a leader, maybe how do you think about what you want to do strategically within the organization versus tactically, and just maybe how you're starting to go about that?
Yeah, I think when you say tactically, right, I think about our nurses, right? I think about our case managers that are out there. They're addressing the health of our members, but there's so much other stuff that comes along in that relationship that they need to be knowledgeable on to be able to really care for the member. Obviously strategically, I think any Medicaid plan, in the country, you have 2 goals, right? One is you want to improve the health of your members, right? That's why we're here. That's why we get paid. But another reason is we have to make money as businesses, right? And so luckily for us, those 2 go hand in hand, right? So you never have a conflict there. And I think that, as you're trying to, help your members and get a healthier membership, your business will do well too. But so much of that is tied to this. strategically, we have to understand, what social factors are impacting our members and keeping them from really being healthy. And again, right, every time a member's going to the ER, every time the member's going inpatient, they're not really getting healthier, right? They're getting care. It's temporary. Then they're coming out, and it's going to end up happening again. So I do think that from a leadership perspective, I'm looking strategically at how we can help, our getting our members healthy and being just a better plan as a whole, strategically, tactically, right? I think about my outreach workers and our case managers that really on a day-to-day basis use this knowledge to kind of do what they're doing to help these members.
That's great. Another question, and you answered some of it before, but I want to double down a little bit because I think many times maybe we aren't thinking about the recruitment and retention when we think about social risk and we think about people enrolled in programs. And I think they're two different things, right? So one is the hypothesis, if we are delivering services and support interventions, does that impact retention? But the second, and you talked a little bit about that before, so if you anything to add there. The second though piece is, how do you think building these programs, building these interventions, building these commitments, partnerships in the community and supporting your members, how does that impact growth for you all?
It's huge. I mean, from a Medicaid perspective, generally speaking, we all have the same doctors, we all have the same networks. So, we're all able to offer a lot of the same things. And so if you're able to really, bring on other programs and things of that nature that really address, the full scope of someone's life, right? Like we talked about other issues that they might be facing, the day-to-day, grind that most of our members are going through, helping them get access to food and transportation and housing and all that stuff, and then ultimately healthcare. That really is the optimal member experience, and we know that, because other than that, you're just paying claims, right? And you don't ever want to be an insurance company that's just paying claims, because anybody can do that. And I think that our role is to do so much more. And I think that's what we've been talking about for the past hour is being able to incorporate that into our day-to-day. Because ultimately what we're seeing now is members that are drawn to the plan because they say, my neighbor or my friend told me, like, you guys are doing this, and that. I didn't know you could do that. Or, I didn't know you could get, I have credit issues. I didn't know you could get credit repair. Or I didn't know you offered Zumba and exercise classes in your wellness centers. Like, I'd love to be able to do that because I don't feel like paying for a gym membership. People are hearing about it. There's a buzz that we're more than just a company that pays claims. We're able to offer a lot more for our members. And once they're on, they stay. And churn rates are high in Medicaid, as you probably know. So all of the plans on the call here, people come in and out, in and out. But a big part of what we're doing through the work we're doing with you guys is engaging more so that they're not going out. It's in, they're not coming out. And that's the goal for us.
Yeah. No, and that's, to me, I think for us and around the country, like measuring that impact, I think really matters. And I would, like you, share the belief that if you are listening to your members, you understand what their needs really are, what they want and what matters to them. And then you start to fulfill that for them, that they're going to stay. We talked before about trust, like you're building trust along the way by doing that work, which is so important. It was nice, actually, somebody just posted that question I was asking anyway, but asked about retention. So that's super helpful. I would just ask people, if they have questions, please don't hesitate to put those into the Q&A. It'll be super helpful. Maybe one last question before we see if there are other questions that are out there. You and I have not prepped and talked about this, but it feels top of mind. I've been having a lot of these conversations. We're talking with CMS next week. Any thoughts on reimbursement, and as it relates potentially to risk-adjusted reimbursement that becomes inclusive of social risk, that then allows the plans to be able to invest more? It gets tied more around that. Any thoughts around that important topic?
It's so important, and it's a big topic, and we've been really active in those conversations, because it is one and the same with healthcare. And when you think about government programs, you think about Medicaid, reimbursement isn't just healthcare, right? Because as we talked about, all this is impacting the healthcare. So if we don't start looking at it holistically, when I say holistically, it should be a part of the program, it should be a part of the reimbursement. It should be a part of the overall actuarially sound financial model that we're all, working off of. It doesn't work. And that's how it's been. And the only way for us to sort of get better and start to see these numbers get better, and the only way for Medicaid members' health outcomes to start to match what you see on the commercial side is if we start factoring all those things, because that's what evens the playing field. If we start, including the social risk factors, then all of a sudden Medicaid members are on the same playing field as the commercial members. So being a part of a larger organization now, you start to see, commercial members and exchange members, and you compare them to Medicaid members and Medicare members, and you can start to see that the more we concentrate on these social factors, the more we're sort of bringing those Medicaid members to the same place. And then we can really worry about healthcare. So it's incredibly critical. I don't know if anybody on CMS is on this call, but it's incredibly critical that we include this in the model.
I love it. I want to take a second now. I know Ron, we're about 46 minutes in, and you're going to facilitate. I don't know that we have any more questions now, but I would ask the audience if they have thoughts, questions, and would like to ask anything of George, please jump in.
Or Trenner.
Yeah, or I'm fine. Yeah, I can answer so. Yeah.
Okay, this one is directed towards George. How do you think about social determinants of health and your work with socially determined as it relates to member retention?
Yeah, I mean, I think we talked about that a little bit, but ultimately, I'll say it again because I think it's so critical. You get members on the plan, churn rates are high in Medicaid, and if you really can get an idea of what the member truly needs, you're able to engage with them better. I think a lot of Medicaid plans can relate to this, but more oftentimes than not, members really don't want to talk to you. You can try really hard, but they don't want to talk to you. But I think that when we're starting to notice a change and a shift because we're able to address some of these other things that we're learning through social scape, and that is more appealing to the members. So we're just doing a better job of engagement, having this information, and engagement is leading to higher retention. We're already starting to see it.
That's great. I got a couple more, George. I'm probably full of questions, and you're full of answers, so that's a good combination as part of it. Do you have, when we think about social determinants in the different areas, different social domains, whether it's food or housing, transportation, do you have a sense yet of sort of where you might see concentration in your population based on the work that you've done from trusted to now? And any thoughts on how to prioritize those, and then we'll talk about if not and some of that.
Yeah, and I think that's an interesting question for any of your customers, is that markets are so different, right? So the market that we're in is an incredibly accessible market, right? So the transportation isn't as much of a thing. There's metros everywhere, there's buses everywhere. It's easy to get around, and to some extent, right, access to quality healthcare there's quality healthcare all over the city. So I think that's less of what we deal with, but more of what we deal with is I see a lot of housing insecurity. I see a lot of food insecurity. DC is one of the most expensive, cities in the country to live in, and it's becoming more and more difficult for our Medicaid population to afford to live here. So that's been a big issue for us. And then food insecurity is a real thing, and I encourage all the executives on this call, go out into your communities, spend a day, spend a 2 days, spend a week there, and try to buy lunch. It's interesting because our staff always complains to us that the ones that work in the wellness center saying, like, I can't get a good lunch anywhere. And that's the reality of the folks that live in those neighborhoods. There's no healthy food. You can't get a salad. You can't get, healthy, anything, organic food, all of that. It's just impossible to find. So food deserts is a real thing here. And I'm fairly certain it is in most markets. But when we think about prioritization, housing and food insecurity for us has been the big drivers.
Yeah, I having lived in the DC for 16 years and working with some really thoughtful nonprofits. There's an organization, DC Greens, that's a food justice organization, and having done walks in Ward 7 and 8, when at a time there's 82,000 residents and one full service grocery store. There's such an opportunity, right? And if we understand that, right, then there are lots of ways to make an impact. And it doesn't mean that CHBDC and CareFirst have to build a grocery store, but if we start to understand what those risks looks like, we can start to bring people together around addressing those risks.
Well, and it brings me back to a point that you made earlier. We're lucky in this market because it's an incredibly heavily resourced place. But a lot of the other markets in the country, that's not the case. So when you think about foundations and the work that they're doing, this helps us understand where the issues are in these different communities. That's where the foundations really step in and say, we got data to show that this is a real issue. I got in DC, we're heavily resourced. Other cities aren't like that. So that's where a lot of funds investments can go, is using this information to say, like, there's a real issue, there's a real transportation issue here, and they can help address those issues in those communities. So that's why that work is incredibly important.
Yeah. There was another question in the Q&A. I can answer this after you do too, if you have other thoughts. But what's been the biggest surprise in the data to date in looking at that?
Yeah, I mean, I think that for me, some of the new stuff that you got, and I should let you speak to this first, but with COVID, right? So I know that it's a part of your work that you're doing now, and it's interesting because it's a new thing over the past year and a half, but sort of seeing the drivers on that, right, and seeing the drivers of vaccination rates, and seeing the drivers of how what's impacted everything in and around this pandemic has been incredibly interesting for us, because you kind of, after a while, you understand some of the issues that are going on in our communities, but with something so new, it's a new challenge that we're all trying to navigate, right? Not just folks getting sick and getting infected with COVID, but then the treatment aspect of it and the vaccination aspect of it. But I'm interested to see what your answer to that would be.
Yeah, so I won't dive deeper on the COVID. I think you're exactly right, and to see the clusters where and that link to social risk maybe wasn't surprising. It was unfortunate to see. I think it played out. Vulnerable communities of color more often than not, for lots of infrastructure and other reasons that were going on, systemic racism and other things that have happened across the country for centuries that led to that. Some of to me, maybe the biggest surprises, one was the recognition that Medicaid members do not all look the same, right? This amazing diversity in members, and again, all walks of life. You did a great job describing before, from families to the single mom, working people, mental health, other individuals with lots of chronic disease, those with none as part of that, and being able to see how that risk plays out across a whole population. The other surprise might be that it isn't always maybe the primary social domain that you think is going to be linked to a disease or a cluster of diseases as maybe the biggest driver. So it's not always food insecurity and diabetes as an example that's the biggest driver. And I know, in looking just as an example up the road from us in Baltimore, when we've looked in West Baltimore, housing instability is the #1 social domain linked to diabetic poor clinical and financial outcomes in the diabetic population there in West Baltimore. And it doesn't mean that food insecurity isn't, but it could be easy to start to make assumptions without looking at the data that I already know what the problem is, right? I know where the problem is, I know what the problem is, as opposed to using the data to actually inform some of those decisions. I don't know, George, if we have any more questions there. So maybe we talked about some advice before, but I always like to ask the question as well, like, any thoughts on maybe missteps or things that you wouldn't do? Like, you talked a little bit about things that you would, but in a spirit of transparency, any things that you were like, we tried this and it didn't hit, like it didn't work, and how you learned from that?
Yeah, I think what we've become overly dependent on in the last year and a half has been, virtual activities and virtual programming, and it's been really difficult because I think, what we've been guilty of is trying to rush to solve a problem that will take some time, right? So if you think about all the things that we're learning from SocialScape and the different issues that our members are facing, we have wellness centers and we have community centers, but they've been closed because of the pandemic.
Yeah.
And so in a hasty rush to sort of address problems, we're putting money towards a lot of virtual activities that just aren't getting traction with the community. So I think that, what I've learned is take the data and really digest it and really use it to develop something that's going to make sense from your population. So I think I got a little overexcited when I started seeing numbers and data and all this stuff coming from soldiers. This is fantastic. This is what we need. But you can't rush the solution. I think the best thing for companies and folks to do that are using the system is, digest it, understand it, learn it, figure out how to use it in a way that makes the most sense for your members.
Yeah, and maybe I'll leave this and then I'll let you, as we're ending the session, just any closing additional thoughts that you might have. But that the reality that it takes time. So two things maybe from my last comments. One is listening to the community and using the community as a significant resource, hearing what matters to people, to organizations that are in this community, and how vital that is for an organization. And then the recognition that it takes time. And it doesn't mean that you can't see early results, and we should, and there are lots of ways to think about that. But addressing real risk and driving long-standing impact for the members that you have the privilege to serve takes time. Takes thoughtful, disciplined approach that ideally is informed with data as you do that. And then it takes time to be able to see those results. George, any last thoughts before I thank you for your amazing contributions over the last hour?
No, but it was really fun to be here. It's always fun to talk to you, Trenner, right? So whether we're being taped on a Zoom or whether we're just doing it on a normal basis, there's so much opportunity for us to do better. And I think as soon as all of us can just admit that and acknowledge that, we'll be in a much better place. But I come from a place of a small plan where you're almost too ingrained. You can't take a step back and be objective on what our population needs. And then also going to a larger organization, which is just so far removed, right? The magic space for all of us to be in is in that middle space, truly being objective and using real data to understand how we address the issues that our members are facing. And so I really want to thank you and your organization for being a part of the solution for us. We need a lot more of that to get where we need to be, but I want to say thank you and thanks for having me today.
Well, George, thank you. This was a great conversation, and yeah, I appreciate all of the ones that we get to have and will have as we go forward. This is hard work, but for those of us all on the phone here today, this is also our life's work, right? This is the privilege, the opportunity that we can actually have real impact in individuals, families, communities across the country. It's pretty special. So thank you for your participation today, for your leadership at CHPDC, and the work that you all are doing. So thank you very much. Ron, thank you, and thanks ACAP for the opportunity today, and thank all the participants. Really appreciate everybody listening in. Hope that you found this information valuable for sure as part of that. If Brad Rose, who's one of our execs, anybody that has any questions or connections even to George as part of that, please don't hesitate to reach out. We really appreciate the opportunity to be partners, George, with you and with folks folks that are on the phone today. So really appreciate it. Ron, thanks so much for hosting and allow us to be here today.
Well, thank you, George and Trenner, for your very engaging and informative webinar today. I'd like to remind the attendees that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks again and stay safe.
Thank you.